It's a very good question. I think it's a word of mouth. Patients actually write their experience, share their experience on different social media areas and Facebook groups, etc. And I can sit here and talk about my experience, or others can sit there and talk about their experience. But patients like to hear from other patients and see how they experience the whole process. And I think we are doing well. It's interesting that the vast majority of cases are the complicated cases, or the redo ones that maybe did not do well in certain places, or cases that require maybe a combined intervention with embolization and ablation, and our protocol to do the ablation first. Or in cancer cases, actually it's the vast majority now of our cases are a lot of that are really the cancer cases. I think perfection is a key. I tell this to anyone: perfection, precision. So you need to start with easy cases, benign nodules that are smaller. We know from published literature that larger nodules, more than 4 centimeters, or nodules that are extremely vascular, or stiff nodules, as we published, are the ones that will respond less. So you want happy patients. You want to start with the nodules that are not complicated or have a higher chance to respond. And accordingly, you will have good outcome and patients are happy, and then you will have good reviews and patients can trust your expertise. But I also want to highlight that good training and good preparation is a key, meaning spending time and effort and attending more than one training session, and watching and observing more, and maybe have someone to proctor you in the first session that you do. Just make sure that you provide the best care to your patients without complications. Because if complications happens, it might really affect your practice. But precision, perfection, spending time and effort, and the training. I did travel to Korea and Italy before I started this, and in my practice I used to do a lot of biopsies, etc. Before, and we used to do a lot of ethanol ablation before any of this. I had a lot of research done on other ablation modalities like HIFU in the lab and all that. So I was interested in this topic significantly, but it's a reality now and it's not going anywhere. And it's a great modality to treat many patients with thyroid cancers or thyroid nodule, or mostly the autonomous hyperfunction nodules. That's another topic. For autonomous hyperfunction nodules, there's good published data that the smaller the nodule, the higher the chance that they will respond. So if you're trying to burn a very large hyperactive nodule, maybe there is a chance that it might not respond well or have a higher chance of recurrence. So maybe this is not the best nodule to start with. You want to start with a smaller nodule to have good outcome and happy patients. And you can feel good about what you offer.